I'm Dr. Anita Stewart. I'm the Nicholas Intervention Coalition Intervention Chair, and I'm also the health officer at the Nicholas County Health Department. I'm a local family physician in this community and have been working at the health department and with the NIC for the last year and a half. So again, thank you for taking time out of your busy day. I'm just interested, just so we can kind of get to know and get a feel for who's in the room. Can I see if you work in local business, please raise your hand. If you work in local government, raise your hand. If you work with high-risk youth or youth in general or in the school system, raise your hand. Oh, good, thank you guys. If you work in healthcare, raise your hand. If you work in prevention, raise your hand. Great. If you work with adult education, raise your hand. Great. Great.
What about the unemployed?
Well, trying to learn. If you're a citizen here trying to learn, raise your hand. That should include everyone. We're all here trying to learn. So again, I appreciate everyone taking the time out to come to try to learn more about, number one, what's happening in Nicholas County, and number two, how we can be better together as a community. This idea for this meeting came after I listened to a podcast about the city of Baltimore and how it has become designated as a city of healing. And that was a designation. They won an award from the Robert Wood Johnson Foundation this year to celebrate that. And what they did to get that recognition and to get these accolades was they created a trauma-informed city. So all of the partners, anyone that worked for the city government or worked in collaboration, so Parks and Rec, local governments, school serving organizations, any organization that would work with youth, they all became trained in trauma-informed care and how trauma affects our youth and adults in our communities. And so by doing that, they were creating a culture of health in their community and received that award. And when I heard that, I thought, well, gosh, if they can do that in Baltimore City, which is so, it's huge, it's way bigger than Summersville and Nicholas County, why can't we do that here? This community, guys, coming in from an outside community and county, seeing how this county really pulls together, we've seen it in times of adversity, we've seen it at the Little League fields, we see it at school events. This community cares about our children and cares about one another. And so if we can garner that enthusiasm and support to learn and to grow and to be better humans on this planet and for one another, think about how amazing our community could be. So this is what I consider is like the first step to kind of bringing people, everyone together into the fold, working together and collaboratively to solve our problems. If we can work to solve problems related, today we're talking about mental health and substance use disorder, but if we can figure out how to dissolve barriers related to that, we're going to be healthier in our preventative care needs, we're going to have healthier children, we're going to have less chronic disease, we're going to be a healthier community. So this to me is considered a first step to that. So again, thank you for being here. We'll start our program. Just a couple housekeeping things about the facility. Bathrooms, if you go out of this room and to your right, they're right straight ahead, you'll run right into them. Out in the foyer, there's different organizations in our community that help in the behavioral health and treatment capacity, have tables set up. At our breaks, we will be offering naloxone training as well as the capacity, if you want to sign up to be a member of the Nicholas Intervention Coalition, which I encourage everyone in this room to be part of. If you want to sign up for that today, that's here. We also will have naloxone available for distribution if you do the training. And Jeremy, if you want to wave your hand, Jeremy will be helping facilitate that training with Seneca for the NIC. To my left is where we'll have lunch today. And there'll be coffee and there's tea and things like that available during breaks, and I think there'll be some snacks there, and then like I said, we'll have lunch. If you had a dietary need, I know there was a few requests and allergies, please come see me because we do have that arranged with the dietary staff here to make those accommodations. So without further ado, just quickly look at the agenda. Like I said, we'll have 2 breaks built in. The beginning part will be covering the data, kind of what is the picture of Nicholas County, what are we seeing, what are some of the structures that we already have in place. After that, Cheryl Jonice with Community Connections will be speaking on addressing stigma. How can we all grow and learn so we're treating one another and can be healthier together. And then the third session will be strategic planning. This, guys, you might feel a little bit out of your comfort zone doing that, but please know that you all have an area of expertise. I mean, you saw all the hands go up when I asked different capacities that you serve in. You all bring something really special to the table as not only where you work and contribute that way, but you're also citizens in this community or in surrounding communities. So please share your thoughts of how, number one, how you can contribute to change and how you think what opportunities we might have as a community. So we'll go into that a little bit more detail as we get closer to that time. So without further ado, I'm going to have Andrea Cook come up. She's going to start a presentation. Amy Cook will be doing the data presentation, and then myself and Kimberly Riley will be doing the adult piece of that. So, all right, Andrea, you want to introduce yourself and then?
Yeah, sure. So my name's Andrea Cook. I'm a person with lived experience. I have been working and serving in Nicholas County for about probably 6 or 7 years, working towards substance use solutions in our community. And in 2018, the coalition really started and got up off the ground. It's been kind of slow moving, but we're still plugging away and working towards efforts of creating collaboration within the community. So the Nicholas Intervention Coalition, this is our mission: to collaborate with community partners to prevent substance misuse among youth and adults in Nicholas County by raising awareness, using evidence-based programs, advocating for policy change, and implementing environmental strategies. Our vision is to build a safe and healthy substance-free community for the youth and adults in Nicholas County. As the coalition members, we are all here as volunteers. All of the people who are working in the Nicholas Intervention Coalition, we are all volunteers in that capacity. We have an executive committee and we have 4 subcommittees that are always looking for new members and new ways to get the community involved with that. For more information, you can scan this QR code and you can visit our Facebook page to find more information about who we are and some of the things that we've been doing in the community. The what, the who, the why. So the Nicholas County Youth Prevention Survey is a survey that we've been doing. We've collected it biannually in the fall in 2020 and in the fall of 2022, and it's given to 7th, 9th, and 11th graders. The focus is tobacco, e-cigarettes, alcohol, marijuana, prescription drugs, and opioid painkillers. We're hoping to be able to partner with the Board of Education to be able to administer the survey again for 2024. So the Nicholas County Youth Prevention Survey, the data identified as most important in measuring the drug use and perception among youth is annual and monthly use, where students use, when students use, their core measures. It's reported 30-day use, perception of risk, perception of parental disapproval of use, and perception of friends' disapproval of use. So federal agencies have identified that these factors are the most important and are assessed in this survey. So risk factors. Risk factors are characteristics at the biological, psychological, family, and community or cultural level that precedes and are associated with a higher likelihood of negative outcomes. When I think of risk factors, I think of like anything that could potentially put our child at risk, anything. It could be something very minor, as alcohol being in our fridge in our home, or it could be something much larger, at like a parent being out of the home or grandparents raising the family. Protective factors are characteristics associated with a lower likelihood of negative outcomes or that reduce a risk factor's impact. So protective factors may be seen as a positive countering event. So when we put these protective factors with children who have risk factors, it creates resiliency in their lives. So some risk factors are fixed, others are like family income, peer groups, or adverse childhood experience. Those can all change over time. So why does it matter? The importance of community. Adolescents who feel a strong sense of community connection and are equipped with the tools to resist harmful behavior are less prone to engage in substance use and associated activities. When educators, parents, and adult figures impact refusal and resistance skills to teens, it significantly raises the chance of them avoiding risky behaviors. So how do we do that? We do that with the strategic prevention framework. So with the strategic prevention framework, there are 5 steps and 2 guiding principles. Prevention planners are pressed to put in place solutions to urgent substance misuse problems facing their communities, but research and experience have shown that prevention must begin with an understanding of these complex behavioral problems within their complex environmental context. So these are the 5 steps. The first one is assessment. We must identify the local needs based on the data. Capacity. We must build local resources and readiness to address prevention needs. Planning. We must find out what works to address prevention needs and how to do it well. Implementation. Deliver evidence-based programs and practices as intended. Evaluation. Examine the process and the outcomes of the programs and practices. That's one that I'm not really fond of, because it's like, what did we do well? What did we not do well? So it's tough to hear that sometimes, what you don't do well. But it's so important to know what you don't do well so that you can improve on it, so that you can build on it and make it better for the next time. So this survey is the first step of the 5-step process. The NIC is part of the second step. The other part is, what can you do? The goal of sharing this information is to spur on creativity and engagement. When we know what the issues are, we can examine our resources and find out ways to address the problems. As you listen to the rest of the presentation, please write down notes. Not only brainstorm ways we can effectively address these issues, but how can you help address these issues? These are community problems, and it will take involvement from all members of our community to make this better. Sorry. So the 2 guiding principles, these 2 guiding principles should be integrated into all 5 steps of the strategic prevention framework. So these 2 principles should So they are cultural competency, the ability of an individual or an organization to understand and interact effectively with people who have different values, lifestyles, and traditions based on their distinctive heritage and social relationships. We definitely understand that being a part of Appalachia. And the other one is sustainability, the process of building an adaptive and effective system that achieves and maintains the desired long-term outcomes. So they must be a part of each one of those steps as you're walking through that process. So what do we know? There's no one silver bullet or single strategy to prevent drug use. No single policy will stop the misuse. No one curriculum or program can eliminate drug use in your community. It takes many coordinating strategies to change specific behavior. So the goal is to create strategies that empower youth to make healthy decisions, as well as create family, school, and community environments that promote and support healthy decision making by our youth. We want to impact the availability of drugs, change community norms around drug misuse and addiction. We want to reinforce the importance of policy and practices that can prevent drug use. And this is how we do it. We do it by providing information into the community, enhancing skills of individuals in the community, providing support, changing access and barriers, changing consequences, incentives and disincentives, changing our physical design, and modifying and changing policy. I believe that is where the end of my part of this presentation. Thank you all for your time, and I would like to introduce Amy Cook.
Thanks, Andrea. I can't be tied to a computer, so I'm going to make sure this works. Yeah, we're good. Okay, so I'm going to talk to you about the data that we did in the school systems. So this survey was done in the fall of 2022, and what's important to remember as I go through these slides is that this is the data from the kids in our county. This is not national data. This is not even statewide data. This is from the schools and the communities that we live and work in. Okay, so as we go through these, just know this came from our kids 6th through 12th grade. Okay, so what we saw with substance use reporting is that 15% of the students indicated illicit drug use in the past year, or drugs that are illegal in the past year. 9th and 12th grade is what we looked at in terms of our numbers. We had 12% in 9th grade reporting that they were using drugs, and 24%, so double by the time they got to 11th grade, just within that 2-year span of students that reported drug use. Our survey actually looked at, and Andrea mentioned this, 7th, 9th, and 11th grades. So something important to look at when we look at the common drugs that were reported used by students in Nicholas County, let's remember that e-cigarettes include vaping, which we know is an extreme problem in our schools right now. So that's all encompassing of the vaping, e-cigarettes, all those different terms that you hear. And just so you know, if you weren't aware, nicotine is considered a stimulant drug. So that's why we have it listed here in our most common drugs that are used in Nicholas County. So you can see the e-cigarettes, the vaping, that is the biggest problem that we have. Alcohol was second, marijuana next, cigarettes, regular cigarettes, and then other drugs, which would be things like prescription medications. When we talk about prescription medication, obviously not if they were prescribed something to take because they had a dental procedure or what have you, but getting illegal prescription medication that doesn't belong to them, sort of thing. Okay, so where are the students doing the drugs in our communities? Well, you can see overwhelmingly that's happening at home, okay? It's either at their own home or at their friends' homes, but kids are going to the homes that we live in, and that's where they're using their drugs. And I think that's a real eye-opener for us as parents, because a lot of us think that we protect our kids, that we have safe and healthy homes, that nothing like that would ever be happening there. But they're telling us, our kids are telling us, yes, it is happening there. So let's all be aware of that. We also see at school, we've got about a 33% usage, which I think is, for school administrators and teachers, probably not a surprise, but for the rest of us, we're probably wondering how that happens during the school day. 35% usage in a car. So let's take into account the danger that's involved with using substances while we're in a motor vehicle, and then other places as well. So what we do know by looking at that percentage, though, is that because most of the kids are doing drugs at home and fewer at school, this is a positive thing. This is telling us that our schools have clear boundaries about substance use within the school system, and that they're enforcing those so that kids know, oh, I shouldn't do that at school, I should wait, and I'll do that at home or what have you. So that's why that number is a lot less. It's actually a very positive thing for our school system in the county. What we have next is we're looking at the disapproval rates by friends or their peers. This is how their friends feel about other people using substances. So in 7th grade, we see that cigarettes have 79%. In 9th grade, it goes to 70%, and then in 11th grade, all the way down to 56%. And that's across the board with the different substances that you see on the screen. So as youth get older, their friends find it more acceptable if they use whatever it might be, cigarettes, alcohol, marijuana, prescription drugs. We see that trend. So when are students using drugs? Well, here's what we know. Of the students surveyed who said yes, they are using drugs at some point in time, 83% of them said that they're using drugs on the weekends, 47% after school, and then you can see in our little graph, 45% said during the weeknights. So what does that tell us? Again, we have that protective factor of our school systems are safer, right? There's less use going on during the school day. What does that also tell us about our evenings and weekends?
Free time.
What is it?
Free time.
Too much free time, right? We don't have them, we are not engaging our youth enough. Absolutely. We're not engaging them enough to prevent that use on the weekends and after school. So that's something, a risk factor that we need to look at in our community. We know that when youth are engaged in different programs, whether it be sports or clubs or all the different things that we can have available in our communities, after school programs, those sorts of things, they are much less likely to be using substances. So this is what we know about extracurricular engagement with our students that they reported. About 40% of them are telling us that they've never been involved in school sports. About 35% are telling us that they've never been involved in school activities. That might be things like clubs or bands or different activities offered by the school. And 53% of the youth reported never taking part in community activities. 53, so over half of our kids said they've never taken part in a community activity. And that, I think, is where the people in this room can make a big difference, right? You're working in these different fields, you have a lot of things that you can offer to the youth, and this is where we can step up and offer these community activities that engage kids. So the thing is, we can't just offer them though, right? I'm sure everybody in this room has offered at some point in time an event or worked at an event and nobody showed up. So it's not just that we offer them, but that we actually engage the youth, really connect with them to get them to want to come to whatever activities and programs that we plan. A slide on suicide prevention, because we know that mental health and substance use disorder go hand in hand, right? And we know that oftentimes when youth get involved in drugs and they get in that cycle of drug usage, that things like suicide can become a problem. So here's what we found out. We see increases, which is really concerning. You can see the numbers in 2020 compared to 2022. I believe it's 2022. We had an increase in the percentage of youth that said that they had thoughts of suicide, had attempted suicide. And so another reason it's really concerning is that suicide is the third leading cause of death in youth ages 10 to 24 years old. The third leading cause of death is taking their own life. So this is a big deal. And anytime we see a trend, even if it looks small on the screen, a trend in that direction is a negative trend that we have to take note of. We have to be ready to act and do what we can. So here's what we know about family life of the youth that were surveyed in our school system. So when we look at parent disapproval, so we looked at their friends, the peer disapproval already. When we look at the parent disapproval by substance and grade, we sort of see similar trends, right? In 7th grade, we had 87% of parents that disapproved of the use of cigarettes, and this is reported by the youth again, not by the parents. In grade 9, we had 91%. In grade 11, we had 86%. So I want you to note a couple of things. One is that by the time we get to grade 11, for most things, again, we're seeing that even parent disapproval goes down a little bit, right? As the kids get older, the disapproval on the part of the parents gets a little bit more lax. But I want you to notice too grade 9, and we'll talk about that in just a minute, but we see some different figures in grade 9. Some of those go up for us, right? Compared to 7th grade. Do you think it's because parents want 7th graders using substances any more than they want 11th graders using substances? Definitely not. There's a reason that we think that's happening. We'll talk about it in just a minute. So what they told us is that 95% of the kids that we surveyed said, yeah, our parents set very clear rules for us. They have boundaries at home. We know drug use is not acceptable. There's consequences. We know it's something that our parents don't want us to be doing. So that's great, right? 95% of those parents have those rules and the kids understand them. And that's definitely going to be a deterrent to drug use. However, what we also found out is that only 29% of those kids told us that their parents had actually ever discussed the problem, right? Or 29% tell us they never discuss the problem, or they seldom discuss the problem of tobacco, alcohol, and drug use, which means they know there are rules at home, but they don't know the reason behind them, right? The parents aren't talking to them. It's more of a authoritarian, just because I said so kind of thing. And we also know that when kids actually understand and we have conversations with them about our decisions, about our rules and our boundaries, they are much more likely to follow them and to agree with what we say and not do that thing that we're asking them not to do. So it's important that we not only set the rules, but we also talk to them about why we don't want them to be using substances. So now we have the perception of risk by the students themselves. This is what they told us by grade. In 7th grade, you can see with the cigarettes, again, we have a 77% perception of risk by the students. In grade 9, it goes up to 86%, but by grade 11, we see that trending down again. So kind of the same thing that we saw with the parents and even the peers. What we see is that over time, it goes down. So their peers think it's more okay by the time they get to 11th grade. Their parents are a little more lax by the time they get to 11th grade, and even their own perception of the risk is less by the time they get to 11th grade. But I want you to again look at what we have with 9th grade. So we see from 7th to 9th an increase in the perception of risk across the board, really, and there's a reason for that. So what we know is that, well, let's talk about the trends for a moment with the car rides. This is an important piece too. In middle school, 97% of our kids reported that they've never ridden in a vehicle where someone was using alcohol, the driver was using alcohol. But by high school, that percentage dropped to 95%. So you can see in our chart, and then we have similar trends with the marijuana. So in 7th grade, much fewer people report having been in a car where someone was driving and using alcohol or marijuana than by the time they get to high school. We see those numbers change. Of course, we also know that by the time they get to high school, they're riding in cars with people other than adults and their parents, right? Because their friends can drive and those sorts of things. But this is a scary thing to think about, is that more of our kids, are getting into cars with impaired drivers at that high school level. So it's definitely conversations that we want parents to be having with their children about how important it is to not do that. All right, so education is absolutely the key factor here. And what we saw with those charts that I showed you where we had that, those numbers in 11th grade sort of trended in a better direction, right? Well, the reason we think that is happening is because we know, or I'm sorry, in 9th grade, not 11th grade. In 9th grade, we have health programming in our school system that addresses these things. And so that is where we think that intervention piece is happening, so that by the time kids are in 9th grade, they are thinking, oh, this is worse for me. And their friends are less accepting of the substance use. But we also saw that in the parent chart as well, didn't we? So kind of getting away just from the data here for just a minute, when I think about that myself, you know, my own kids, I think, because the parents didn't go through the educational component, right? Now, maybe the school sent some things home. Maybe there were handouts that were sent home and the parents saw them. I could see that happening and causing an increase in parental awareness during that grade. But what else do you think might have been happening that changed the parent perception as well?
Transitioning to high school.
Okay, so good, absolutely. I think that shift from middle school to high school makes a difference, because parents think in middle school, oh, they're not doing those kinds of things, right? No way are they doing those kinds of things. If anybody here is from the school system, you can stand up right now and tell everybody in this room they are doing those things in the school system in middle school. But I think parents think as they transition to high school, this is a little more dangerous, right? More things are going to be happening, and so I need to, be really clear about my rules and how I feel about those kinds of things. What else, though?
Education in the school.
So the education is happening in the school. How do you think that's getting back to the parents?
Kids are talking about it.
So I think you're right. And this is purely speculation on my part. But I think the kids are going through those health classes and getting that education and then going home and mentioning it to mom or dad, right? And saying like, well, they talked about this today and why? Or what do you think about that? Or those sorts of things. So really interesting, I think, because we have kids reporting that their parents aren't talking to them, but then I think they might be going home and talking to their parents. Some of them are. And I think that's why we're seeing that shift as well, even at the parent level. So for all of you out there that work with parents, it is difficult to have those conversations sometimes. I work in this field. I have 2 kids in middle school, and sometimes I just think, I just want to go to bed and not have to talk about that one thing that happened today or that I heard about or whatever. I just would rather go to sleep. But it is so important that parents are talking to their kids about these things. It is imperative that we're having those conversations at home. So I think that pretty much takes us through the Pride survey, and Anita's going to come up and talk about some local data. All right. Good job, Amy.
All right, guys. So some of the data we'll be talking about today has been pulled from local partners. Seneca, which is one of our local behavioral health systems, has pulled some of their data to also share forth. So this is from the county health rankings. It kind of shows where we are in Nicholas County, staged in West Virginia. Now remember, West Virginia is ranked last at nearly everything. So when we're ranked 37th out of 55 counties in West Virginia, that's, even though we're not the worst in West Virginia, we're still some of the worst in the country. So I like to frame that just because I think it's really important that we have to strive to be not only the best in West Virginia, but one of the best in the country if we're going to really raise a healthy community. So health outcomes are things like, what's causing people to die early or prematurely, how many premature births are we having, those types of things. Health factors are things like, how many smoking adults and youth do we have, mental health, what people's perception of their mental health is, and physical health as well. So you can see here, guys, that the poor mental health days, well, it might be hard to see from the back of the room, but in Nicholas County here, that Nicholas County is at 5.8, whereas West Virginia is 5.7. So we are actually worse for poor mental health days in Nicholas County than in West Virginia, and certainly much higher than the United States at 4.4. So the national guidelines or the national statistics have that 1 in 5 persons, adults, have had some kind of behavioral health disorder, so depression, anxiety, those types of things. It's Mental Health Month, so you're hearing a lot about, how prolific this is in our communities, but it's really something that we aren't talking about very much. So when that's being said, so if you imagine, we have 24,000 people in our community, in our county, and if 1 in 5 of them has a behavioral health disorder, we should have 15 behavioral health facilities here, right? If people were going to get care and seeking out therapy and going to get care, we would never have openings, we would never have access, we would need lots of providers. And that's not really the case. So as a public health person in this community and as a healthcare provider here, what I believe and what I see and what we are seeing in data from our local partners is that it's not necessarily that those things aren't available here, but that people just aren't seeking out those services, that it's taking sometimes weeks and months and years even for persons to kind of get the, I would say courage loosely, in parentheses, in quotations, to go make that appointment. So there's a delay in care, and that's typically because of stigma. This is data from West Virginia. I wanted to share this. So this talks about, you can see about mental health status in our community, and then what the suicide risk is for mental health. And so as Amy showed us earlier, that our youth data has continued to increase for mental health disorders and suicidality. We're also seeing this in our adults. And so again, to create a healthy, well community, we have to think about the whole family together. That includes not just the parent and child unit, but grandparents, aunts, uncles, coaches, school personnel, everyone that's surrounding that child to help rally, or that community to help rally. We need to be bringing them into the fold together. Alcohol use and drug use, we can see that those trends are they're prolific. We're seeing 15% have had some kind of binge drinking or alcohol use disorder. 25% have had some types of drug use in the past 12 months. So it's in our community. Again, this is West Virginia data, and the data in Nicholas County is very similar to that for adults. Cigarette smoking, we are the worst in the country at that. We're beating out all the southern states for tobacco use. And then certainly if you provide care to pregnant or women of reproductive age, we are, I think, 2 or 3 times as high in tobacco use in pregnancy in West Virginia. This is the slide that was provided by Seneca Health Systems. It talks a little bit about, it's from the Connect initiative. And you can see that the lighter the shade on this graph, the more time was spent. People are struggling with nervousness, restlessness, and that they said that everything was an effort. So, I think it's important when we're looking at data, number one, to know that if you look at 1 in 5 of us in this room, it's prolific here. And it's something we need to be sensitive to, open to talk about, and ready to strategize about how we can make that better. And not just in a direct care model, but as a community care model. This is from the Office of Drug Control Policy. This is available, a dashboard that's available for us. This is 2023 data, and you can see that there were 57 calls for suspected overdose in our community. And this is down compared to the previous year, and I do think that's related to our excellent work in getting naloxone into communities, so people are saving one another, which is great. We have.
I think this was just through August too.
No,
So
this is.
Is that all of them? I thought it was just through the.
Oh, it is through August. I
Yes,
don't know
through
why.
the end of August. They haven't updated it yet.
Oh, good.
Yeah, so we're
Good.
missing
Yeah.
a quarter of the year.
Well, so through August.
Sorry.
So, yeah,
Sorry to
so,
burst your bubble.
So we are probably higher than last year, but or the 2022 year, but what we can see is that it's equally affects males and females just about, and that it covers the whole age gamut. We'll talk just in a few minutes about pediatric overdoses, so 0 to 17, just just a second, but this is just for adults only. For our state reported data. So for our emergency department in Summersville, we had 9 cases come in that were coded as overdose for 0 to 17. I mean, let that sink in for a second. 9 kids, guys, went to our ED for overdose. It's preventable. This is the I guess the Department of Human Services now. This is the Children in Foster Care dashboard. We currently have 107 kids in foster care here. So I think as we're talking about family units and the language that we're using, that we need to be very sensitive to the fact that some kids aren't with their parents. Sometimes they're not with grandparents. So being thoughtful about creating a loving community that surrounds kids to wrap them up. So we talk in protective factor language, it's having a loving, caring adult. So making sure that they have that person, whether that, again, is a coach or a teacher or a counselor or a pastor, whomever, really rallying around as a community. You know, everyone in this room could be that loving, caring adult for those kids. So think about that as your role here. One of the things that every state in every county in West Virginia has, it's called Handle with Care. And that's a program where kids that are removed from the custody of their guardians, that is to be reported to the schools. So when the kid comes to school the following day, that the teachers and staff can be notified that they don't know why the child, might have had an issue at their home, but they know that little Johnny might be having a hard day today. So if he's a little bit tired or he's disruptive, we just give him a pass for the day, and we wrap our arms around him as a school and a community to help him have a good day. This year, we had 4 cases that were referred for 7 students. So this data can flag us to a system that is not working. So we know that we have 107 kids in foster care, and I know those probably weren't all from this year, but we know that there are more kids that are being pulled from families and homes and are having bad, incidents, whether it's a domestic violence call at their house or disruptive behavior or, drunkenness, whatever. Those are all cases that would fall into Handle with Care, and again, 4 cases referred for 7 students. This is the Office of Drug Control Policy Nicholas County snapshot. So it kind of tells counties where they're doing well, what they consider like the metrics of things to strive for mental health and substance use, and then some of the things we're looking at. As you can see in the 2023, this is from 2022, but we did have 19 fatal overdoses in adults. So just know, 19 people died that could have been prevented, completely preventable. And this is also in your folder, so because it is really small to see. And some of the data that we have up here is in your folder, but you can see kind of the breakdown of what we're seeing in our community as far as the drug supply. So it's not just heroin. We're seeing lots of xylazine here, xylazine is a drug, and when cut with other substances can cause respiratory depression and cause people not to breathe. It's a sedative that we use in veterinary medicine. One thing that I want to highlight here, guys, that I think is pretty amazing for our community is that we distributed 34,000, almost 4,000 naloxone in our community. So that's potentially 4,000 lives that could be saved with naloxone in the community. And then the other thing that I think is, we can see areas of improvement where we have a lot of these services available, but we need to be utilizing these services. So we have a really strong quick response team here. We have a crisis team in our community. But these are areas that I see that we can improve, and certainly look forward to hearing your guys' during discussion about where we can work together on these things. So this leads us to our next Any questions for any of the presenters today, including myself, Amy, or Andrea, or Kim? Kim helped me with data. She didn't want to present. So. All right. Well, what we'll do now, we'll take a quick break. Again, restroom facilities to our right. There's some snacks to the left. There's also going to be tables set up outside, different organizations in the community. Please stop by, learn what they do. If you're interested in naloxone training, find the Seneca table, find Jeremy. And then if you want to sign up for the NIC, please go to the NIC table. Thanks.
I'll let you do this.
Yeah, let's see. We will be passing out some membership applications in between as we move forward. Next up, though, we're so happy to have such a strong advocate for prevention, particularly in this region. We have Cheryl Jonice. She's with Community Connections, and she is in charge of the Partnerships for Success as the coordinator for Region 6. Cheryl Jonice was born in West Virginia and has lived here for most of her life. She has over 40 years of experience in the field of substance use disorders. She worked 30 of those in treatment and recovery position as the continuum care as a therapist working in West Virginia, Arizona, and Hawaii. She's been serving both youth and adults. Cheryl has worked in a variety of settings, including patient, residential, outpatient, drug court, day report, and youth health, expanded mental health. This is also in your folder, so I'm not going to belabor Cheryl's bio. I want to get to the meat of the presentation. This is where we can really learn and grow together. And so you've heard the quote from Maya Angelou, if you know better, you'll do better. So this is the part where we learn together to do better for our communities. So without further ado, Cheryl, join us.
Thank you. Okay, can you guys hear me okay? I don't know if this is carrying well back there. It doesn't, okay. Okay, thank you so much for the opportunity. I appreciate it very much. I'll start by apologizing for my voice. I've got some allergy stuff going on, but I have some water, so hopefully my voice is gonna hang in there. I'd like to start by just kind of reiterating what the folks that went before me already talked about, Amy, Andrea, and Dr. Stewart. What we do today in prevention, it is evidence-based, it is researched. We really know what we're doing now. When I started in prevention in 2008, community coalitions were new, they were learning, and they were just trying stuff. That's the best way to do it. They would do a mock car crash. They might do a school assembly where they bring in a speaker or that sort of thing. So they were just trying stuff, but now, as Andrea said, we have the strategic prevention framework. It guides our work. It's research-based. We know what we're doing. So I start by telling you that because I want you to know that this presentation is research-based. It's been researched, looked at, and so we know these are the things that we can start to do to reduce stigma. So I'm going to ask, you don't have to raise your hand if you don't want to. Anybody in the room left-handed? Whoa, my goodness, I got to count. 1, 2, 3, 4, 5, 6. Wow. So, I'm not good at this part. So, you're going to be interested to hear this. As recently as 1946, there was a real stigma around being left-handed. It was actually thought that people who were left-handed might be developmentally or learning delayed. And sometimes they really thought that these folks might also be dangerous. So it was a really big stigma. My mother was left-handed, and I remember them trying to teach her to write with her left hand, and it was some of the things they did to try to reorganize the way kids wrote was really kind of cruel. So that was a stigma that was started, and we know there's no basis in that. That's not true. I mean, people who are left-handed just happen to be left-handed. There's no difference. Okay, so, gosh, I'm terrible at this part. So we're going to look at a definition of stigma. It's been actually determined to be one of the greatest obstacles to seeking help in the mental health and substance use field. Think about that, the greatest obstacle. Dr. Stewart talked about perhaps lack of services, lack of resources, but the number one thing that kind of holds people back, even if the service is there, is that stigma, that embarrassment, that shame. It actually does decrease the quality of life. So what we're going to talk about today is the definition of stigma, why it's important, and what we can do to reduce it. All of us have a stake in that. Simple definition. Stigma is the mark of disgrace or dishonor associated with a particular circumstance, a quality, or a person. It's a strong feeling of disapproval that most people in society have about something. We're going to talk about 4 kinds of stigma today. So we're going to start with the first one, which is public stigma. Public stigma is when a group of people start to stereotype or have opinions about, again, another group of people that may have a certain circumstance in their life. It may be that they have an illness, a certain illness. It may be that they live in extreme poverty. But again, it's developed in a societal way. It's one group of individuals kind of stereotyping another one, and then generalizing those beliefs to anyone that has that condition. So maybe we start to stigmatize someone with a mental health issue, and then we learn of other people with mental health issues, so we group all those folks together and we stigmatize every one of those people. I know earlier Amy mentioned that mental health issues and substance use kind of go hand in hand, and that's absolutely true. Sometimes what we see with substance use disorders and addictions, it may start out as a mental health issue, such as depression, and a person may try to self-medicate. A lot of times that's done with alcohol, which kind of doesn't make any sense. If I'm depressed, why am I going to take a depressant drug? But that's kind of what happens. It's simply because that's the coping skill that's there, and that's what they have available to them, and so that's what people start to use. Okay, so public stigma can develop barriers to new relationships. It can isolate people. It can reduce employment because people can be discriminated against because of their situation. And it can reduce access to housing, and other discriminatory things can happen as well. So, I'm sorry, those are the things I just told you. So substance use disorder is among the most stigmatized conditions in the United States and around the world. People don't want to work with, be related to, or even see people with a substance use disorder. Many believe that people with a substance use disorder can or should be denied housing, employment, social services, and health care. So the next kind of stigma that we're going to talk about is self-stigma. So here's what happens. So a person with a stigmatizing condition is really clear and can recognize what the public think of them. So what starts to happen is that person starts to believe it about themselves, and they take it on and they own it. And that can never be a good thing, but that's what happens with self-stigma. So let's just in your mind, think about this. What if you had to go to your supervisor and say, I need some time off, I think I've sprained my wrist? What does that feel like? So what if instead you had to go to your supervisor and say, I need some time off, I need to see a health professional, I'm having some really severe anxiety? How does that feel? It feels really different because, again, the way the public may look at that and the way that I've taken that on myself is going to be really different. Okay. Self-stigma manifests itself as fear, too. It's fear of being judged negatively. And fear is not a good motivator to reach out and seek help in any way. Humiliation, shame, guilt are not the primary engines of change. The same things kind of help them with self-stigma. It can cause isolation. It can encourage a person, to stay in the illness and not reach out and get help. Approximately 2/3 of people with a substance use disorder do not seek treatment, and stigma may be one of the contributing factors in this underutilization. Next kind of stigma. So we've looked at public stigma that can turn into self-stigma. The next one is courtesy stigma. Any ideas? What do you think? What do you think courtesy stigma is going to be?
All these poor people.
I'm sorry?
Like all those poor people.
Could be. It could be. What it tends to be more than that is people who are close to and surround the person with the stigmatizing addiction, they start to be stigmatized. They start to feel it themselves, and the public starts to stigmatize those people. I don't know if you've ever known, we talked about overdoses. I don't know if you've ever known about a family or been close to a family that unfortunately had an overdose, whether that was fatal or non-fatal. What does society do? How do they look at that family, the entire family and friends? So the people who are in the, let's say the person with the substance use of a mental health disorder, they're in their life, they start to feel that same kind of stigma, and often they get treated the same as the person with the condition. And also, sometimes they might feel guilty. They might feel blamed, like, was I part of this? Did I help cause this? What is the issue here? And a lot of this goes back to the fact that, general society does not accept substance use disorder as a brain condition, and it is. It's a brain condition. It starts and ends in the brain, and that's the way that we're going to hopefully get out of some of it. So things that can happen with courtesy stigma is, I'm sorry, I skipped a page. It can isolate the family members, isolate that unit. It can lead the family members not to really encourage that loved one to reach out and get help. It's like, oh no, let's just hunker down and, let's not go out and try to do anything about it. I mentioned it can create a sense of shame. And again, they're less likely to encourage people to go out and get help. So that brings us to the fourth kind of stigma that we're going to talk about, which is structural stigma. So public stigma kind of creates the stereotype. Then the person with the condition takes that on and owns it. Then people who love and work with that person take that stigma on and own it. And then it comes to policymakers. We have folks in our communities are powerful. They have the power in our community. It's our government officials, it's our teachers, it's our whatever. But those folks in power can make a huge difference in a person's life if those stigmas are looked at and codified with any kind of policy, any kind of rule. So what can happen there is structural stigma can increase barriers for people. It can reduce access to things like treatment and ongoing care. It can reduce employment opportunities, and it can end up in poor health outcomes. So I know a few years back, and I think the law has started to change, but people with federal offenses on their record, it was difficult to get a driver's license, it was difficult to vote. At one point in West Virginia, nurses who were treated for a substance use disorder, their license was taken away, and that's changed. There are certain psychotropic medications that jails and prisons don't allow. So you've got an individual with a mental health condition, and they're locked up in a facility, and they're not allowed to have their medication. So that's very, very, very dangerous. Okay, so again, to review, we've looked at public stigma, self-stigma, courtesy stigma, and structural stigma. Now, we're going to talk about what we can do, what everybody in this room can do to start to reduce stigma. We're going to talk about these 4 ways. We can change our language and our labels. We can learn about the issue. We can learn about mental health issues. We can learn about substance use disorders. We can intentionally involve ourselves in personal experiences with people who have those stigmatizing conditions. And then structurally, we can review practices and policies that we might have in our agency, in our schools, in our community that may be stigmatizing. Now, I'm not saying these are the only 4 ways, but I'm saying these are 4 pretty easy ways that we can start. I'm so used to somebody else doing the clicker for me.
You can do it?
Yeah, if you want to. I'm sorry. I'm just terrible with that part. So, starting with the language, and I noticed when Andrea introduced herself, she said, I'm a person with lived experience. That's telling her experience in a very positive way. She didn't stand up and say, I'm an addict. She said, I am a person with lived experience. She put herself first. She's much more than anything that she's lived through in her life. So language is so important. If I said, Angie is bipolar, that is really, that's really kind of making her and the condition one and the same. But if I say Angie is a person with a bipolar disorder, that's separating Angie and the disorder. Therefore, that means anybody could have that bipolar disorder. Cheryl could have that bipolar disorder. So we're not equating the same, we're not making her one and the same. So person first language, putting the person first. And you can go on to the next one. So language and labels, we're really, you notice we've said many times today, substance use disorder. We're really trying to get away from addicts, addiction, that sort of thing. So we're really changing the language that we use. So let's take a look at the first one. Instead of saying addict, what if I said he has a substance use disorder? That sounds quite different than he's an addict. Junkie, that is so negative. That's just negative, a very negative thing. Instead of saying he's schizophrenic, he has the mental illness of schizophrenia. Crazy. You know, what does crazy mean? She suffers from an anxiety disorder. She has a depressive disorder. It's a little bit better way to say that. Replacement therapy, we used to call it medication-assisted treatment. Now we call it opioid use disorder medication. How about dirty UA? That's a urinalysis screen. Who wants to be dirty? Nobody wants to be called dirty. So instead, we could say she tested positive on her urinalysis screen. Frequent flyer, that's somebody that goes to the emergency room a lot. So instead of saying it in a negative way, oh, he's a frequent flyer, just say, you know, he's had to visit the emergency room several times, you know, in the past month or so on or so forth. Okay, alrighty. So the next one, oh, I'm sorry. See, I'm awful. I'm awful when you're doing it and I'm awful. Okay, so stigmas are slow to change. Think about that left-handed stigma that I talked to you about. I mean, it was, you know, it went on way before the 1949 date that they said that the psychiatrist kind of discovered it. But they're slow to change, even when evidence supports that, that they're not true. So the next thing we can do to change the stigma is to learn more about it, to, you know, become educated about what's going on. Some things that you might think about, you can go to the next one. Some things that you might think about when, oh, I'm sorry, back one, please. Some things you can think about, especially with substance use disorders and mental health disorders, is what do I need to know more about? You know, I said earlier, substance use disorders is a condition of the brain. Well, what does that mean? What does she mean by that? What is the brain science behind it? Learn more about mental health disorders just alone in themselves. We can learn more about the brain science of trauma. Dr. Stewart talked about what they're doing, you know, in other places, in Baltimore City, to address trauma. And again, this is an old slide. It's not medicated assisted treatment. It's opioid use disorder medication now. I'll give you an example where I had to do some education. I mean, and gosh, I've been in this field since 1980. When harm reduction started to be introduced into communities, my knee-jerk reaction, I'll be really honest with you, my knee-jerk reaction was just what I heard in the community, needle exchange. And in my world as a therapist, that came across as enabling. Am I enabling this person to continue their substance use disorder. It didn't take me long to really learn about harm reduction programs and what they meant. It's so much more than a needle exchange. Plus, a needle exchange with a unused needle is much safer to my public health, to everyone's public health, than using needles over and over and over, sharing needles. So first of all, I learned a public health issue. You know, we're going to reduce some of the diseases in the community, hopefully, by using this approach. Then I learned that harm reduction is building a strong relationship with that trusted person that's not going to judge you, that's not going to put you down, but they're going to help you, and they're going to be there when you finally decide that you're ready to go into some kind of treatment. And other things, you know, wound care, practical kinds of things that harm reduction does. So that was an example of me being in the field for a long time, and about, I don't know, 2018, 2019, really having to take a look at my knee-jerk reaction to it. And then can you only imagine people in the community who don't do this work and they don't understand, you know, the real power of it. Okay, you can go to the next one, please. Okay. All right, so this one should be on experiences. Okay, yeah. Okay, so this slide says, what are ways that you can interact more with people with stigmatized conditions? Again, it's going to take some intentionality. You're going to have to be intentional with the actions that you take to do that. Experiences can really change our beliefs, and I'll give you a really good example. I happen to live in Pocahontas County, and we've had a very active coalition there since 2006. And probably in about, I don't know, 2009 or so, we had a town hall. And we had, actually, that time it was Governor Manchin. He didn't attend in person, but he sent a video. We had senators, we had, you know, earlier Dr. Stewart asked about, you know, who's a business sector, who's healthcare. We had people from every sector in the community. It was wonderfully attended, it was great. Also, very important, we had folks who were in recovery, who were in active recovery. We had the editor of our little local newspaper, the Pocahontas Times. So a couple of the folks in recovery actually got up and spoke, told their story, talked about their family, talked about where they were. And that editor, after that meeting, went up to some of those, they were ladies, went up to those ladies and said, wow, would you guys like to have lunch? She was used to taking their photo when they were being arrested, handcuffed, doing the walk of shame, splashing it on the front page of that newspaper. She didn't even know those people. So when she got to hear what they'd been through and what they were doing now, she was so impressed. And then they started having lunch together on a regular basis as a group. Another thing that we can do to actively engage, in the coalition, I know you guys do that, invite folks with lived experience to sit at your table, to participate. You know, it's their life, nothing about us without us. Invite people. Invite them to your church, invite folks to your church, invite them to your meetings, invite them to things that are going on in the community. Okay. Okay, so the last slide, talking a little bit more about access. Ask those that you serve with in various conditions how your practices and policies, how they're acting now, and what you could do to change those things. Sometimes we don't even think about it to really sit down to take a look at, does my agency, do we have policies that limit people from participating, and what might those be? Lots of times it might come in the form of maybe some of your bylaws or some of your membership kind of requirements. So again, a review, ways to reduce our stigma, change our language and our labels, learn about the issue, involve ourselves in some personal experiences, and review our practices and policies. So what if we could change stigma? What if we could reduce it? I would venture to say that we would make life easier for a lot of folks. I think we would be more positive. I think we'd be more proactive. I think we'd be more inclusive. And it is possible. It is possible for this thing to change. I want to share one more thing with you. we are getting there. We have a small farm, and so I get the West Virginia Farm Bureau magazine. And this was February 2024. The West Virginia Extension Service had an article called Addressing Mental Health Resources in West Virginia. And I actually got cold chills when I read this, because it talked about what farmers go through and how stressed they are. And they can't predict what their seeds are going to cost. They can't predict the weather. They can't predict what their crop is going to sell for. They have a lot of stress on them. However, this kind of surprised me. It says residents of rural communities have higher rates of suicide compared to urban areas. And the CDC reports that the 4th highest suicide rate is for those working in agriculture, forestry, fishing, and hunting industries. And yet, lots of folks don't seek help, and here's what they said. Most respondents reported that the cost of help or treatment and embarrassment were obstacles to seeking help. That's it. That's stigma right there. But we're working on it. We're recognizing it. We're reaching out. Also, part of this article, it gave several resources. West Virginia Suicide and Crisis Prevention, the West Virginia Help and Hope, lots of resources. So we're getting there. We are making a difference. We're not there yet, and we need to continue the work. But and I don't know if you have any questions. I put some little fun stuff on the back table. The sheet that Anita has in your binder is there in this form. I've got a rack card with the same information on it. So again, I appreciate being here. I've enjoyed it. And if there are questions, I'll try to answer them the best I can. Any questions, any responses? I saw a lot of head nodding. I saw a lot of people kind of connecting with some of what I said. If there's anything, I know you had some specific things you wanted to cover. Is there anything you want to add, or?
Yeah, you can go ahead right now.
Do you?
Oh, I don't. Yeah. So I'm so glad you brought that, because I wrote that article for the Farm Bureau.
No, you're kidding me! Oh my gosh! Oh wow! No, I really have cold chills. Oh wow!
So we have a grant through WVU Extension. Well, we had a grant, and the funding has run out. We're getting other funding to address rural mental health and stigma. So we have a lot of research happening within the state. Kim's part of our team, actually, and maybe some other people in this room, where we're bringing together people from across the state, from all different agencies, to address the issue. We had a forum at the Small Farm Conference in February, where we had, I think, 87 people come from different communities across West Virginia. But what I want you to know, what's important, why I'm telling you this, is because so we have a lot of programming that we do in communities as well. We have a stigma program that we do. We come to different agencies, or whatever community group you have that would want to do that. It's a 1-hour presentation on stigma. We really go through like the brain changes that happen when substance use is involved, so that people can understand it's not a choice, right? We try to break down those barriers between misinformation that happens when people don't understand what addiction actually is, and we talk about the stigma that comes from thinking that way, and we give you the science behind it. So that's one of the things we do. Question, Persuade, Refer is another program that we offer, which is a suicide prevention program. This is about an hour to an hour and a half long program, and what we do is just in a quick hour-long program teach people how to intervene if you think someone is having suicidal thoughts, or if you're ever faced with a situation, which is less likely, where there's a crisis right in front of you happening, but possible. But it's more likely that you notice somebody at work is seems to be getting a little bit worse, right? They seem a little more depressed. They're not taking care of themselves as well. How can we intervene in that situation before it gets to the point of being a crisis? So we have a lot of different programs, since this is Mental Health Awareness Month, that address those things in our rural communities, because we have fewer resources in our rural communities than they do in some of the more urban areas. So we, as community members, have to step up and be involved and sort of address those issues ourselves. And so just if anybody's interested, I wanted to put that out there, that we have a lot of different programming we can put out in the community.
That is so awesome. I can't believe that happened. like I said, when I read this, I got chills, and when she just shared that, I'm like, oh, okay. Things happen for a reason, so really cool. And again, yes, sir.
I got a question.
Really
to ask
loud,
you.
I have a hearing.
Okay, I got a question to ask you. I've been an officer for 35 years, okay? And I sit back here and I listen to you and everything. I want to know what you would tell me when I get a call and that guy that's on drugs and stuff is trying to cut me or trying to hurt me. Do I say, I know, buddy, you're having a tough time? I mean, I get, you know what I'm saying? I sit back here and I listen to you say that stuff, and I honest to Pete, I love people. But there are some people that I have a hard time loving. You understand what I'm saying? And I just want you to tell me what, and I don't know if everybody goes through it. I don't know if everybody gets a 911 call and say, hey, listen, Joe's down there acting like an idiot, and he's got a knife. Now go down there and you take care of him. So I go down there and try to take care of him. How do you expect me to interact
Right.
with that person?
Okay, I can tell you this, I have lived experience. My husband's a 25-year retired Marine and an 8-year retired sheriff.
And been a
Yeah.
Marine, been in the sheriff's department.
Here's what I would say as far as you dealing face to face with that, sounds like a crisis situation. You're going to have to follow your protocol. You're going to have to follow. At that time, you're not thinking about stigmatizing this person. You're thinking about what you've been trained as an officer to do in that situation. As far as, I mean, it sounds like you have some thought processes about substance use disorder and the stigma. And you're saying, does everybody go through that? I would be willing to say it definitely is a process. You have to start somewhere and take steps. The things we talked about, I guess I should have mentioned in the very beginning, is just be willing to hear what I've said, and it sounds like you have, which is excellent. So maybe just starting to take some of those steps, maybe starting to learn a little bit more about it. Again, substance use disorder, people are blamed a lot of times for having this disorder. Well, he's the one that picked up the needle, or nobody forced him. Maybe that first time or two, but the thing about substance use disorders and addiction is that part of what's going to happen is your genetics are different than mine. Some people can be so susceptible so fast, other people are not. That's just the way it is. So genetics has one thing to do with it, and the rest of it is what Amy just said, what Dr. Stewart has said. It's a science of brain chemistry and what happens in your brain. It actually changes the brain. But again, going back to your point, I would think it's a process. I think if you're willing to take a step to look at it, you might be able to change your thought processes a little bit. And then some people may never change their thought processes. Again, I would think the most important thing is, even if you don't believe it, don't act out against those people. You know what I mean? Don't mistreat them. Don't be mean. That's, I don't have to believe it to act like a decent person.
Right, I understand that.
Something about that. So, just as a person who has walked through substance use disorder, I would say, like, whenever somebody is violating the law, like, there has to be accountability taken in that instance, in that situation. But that individual is still human, right?
Right.
Once they're arrested, once the situation has, calmed down and it's not a threat to anyone anymore, like, how do you interact with that individual? Do you remind them of the stupid mistake that they just made? Do you talk to them like they're human? Do you tell them, man, there's hope for you? Like, it's not just like trying to baby them when you're trying to arrest them, because that's not practical. They're violating the law. You have a job to do. They have to be held accountable. But at the end of the day, that person is still a person, and that person is struggling with something that has led them to the stupid actions that they just caused. So trying to connect with that person on a human level and saying, man, like, what's going on? Like, are you depressed? Can we get you some help? I know Seneca's got this program, or whatever the situation may be, just being a point of contact to point them into the right direction. Because quite honestly, you were an intervention. Like when you meet with that individual, you have the opportunity to intervene in the chaos of their drug use. So that opportunity, like if you guys aren't talking to them about getting help, that is a huge missed opportunity, because they're going to go to jail, they're going to do their time or whatever, and then they're going to go right back out there, right? So you are a point of contact to point them in the right direction, to even have a conversation with them, you know, because when they're out in the chaos, it is just that. It is chaos. It is like a tornado that they're living in, you know? So just speaking with them in a human way and being caring, you know, just caring about that person getting help, because if that person gets help, then it helps your community, you know? It helps the people around that individual, you know, it helps the family around that individual and everybody involved.
Well,
And I would also say that it would help you in your detachment, because if you're able to make a positive impact in that way and taking the most negative experience that person could have had and turning it into the most positive experience that will change and maybe save their life and their family, that's awesome, right?
I know, that
That
is.
feels really good for the person that you're helping, and then for your staff. Like, you guys don't want to be, you know, arresting. We can't arrest our way out of this, guys. This doesn't work. It's not-
and I understand that.
But these are strategies and tools, and we have these things in place in our community to also help bring in. You guys can't do all of it either. It can't just be on you guys.
And I understand that. My thing is, listen, and the devil's advocate here, I guess, you know, I agree with you guys 100%. My question is, I've sat down there and I've tried to get at Seneca Mental Health a guy to go to that little help that you get for whatever. You know what he did? He went up there because he knew he was going to go to jail, and then I find him 3 days later where he walked back out just because he didn't want to do it.
Because that's a symptom of his disease. That's
And then
a
you hear
symptom.
that, and you deal with that constantly. At what point, this is what I'm asking, at what point in time do you say, listen, and it sounds harsh, I know it sounds harsh, but at what point do you sit there and you tell them, you don't want help. You don't want help at all, at all. What point do you do that? And you tell them, you need to step up and get your help, or quit sitting here and whining to me about your problem. And I know it's got
So-
something to do with your mind too. I know it's got something to do with your mind, but we're sitting here and we are all talking about drug people, which I understand, they have problems, alcoholics have problems, people that have, you know, I don't know.
I'm gonna spin it back into, if you were coming.
That's what I want help
Yeah,
on.
Yeah, so I want you to think of this as a disease. So if you have diabetes
Uh-huh.
and you come to see me in my office and you're 100 pounds overweight and your
Right.
A1C is 13 and you're not taking your medications and you're not going to your appointments, you're not doing foot care, you're not getting your eye exams, you have your analysis that has ketones in it, so I know you're spilling all this stuff, everything's failing, I'm still gonna take care of you.
You're still gonna
And I'm
say,
still gonna say, I know that
you
have
don't need that
diabetes,
Big
this
Mac.
is-
You're
I'm
still
not
gonna say that.
no.
You don't need the
Because
Big
do you
Mac.
know why? If I tell you that, does it make a difference? It just creates shame.
At what point in time do you say, listen, you need to be shamed? You need to be shamed. You're a diabetic and you're gonna die.
But we know
I mean,
that.
what we're doing is we're not giving them the truth. We're patting them on the back, love you brother, love you, you got diabetes and you're gonna die, but you know what, big hug for you. And I'm not trying to be mean
The
about
person that
it,
has.
but it's your
If I-
hamburger,
if I
buddy,
could-
it's
person
your
that is
hamburger.
a diabetic and has all those things, they've already.
I'm
had a doctor,
diabetic.
Then you know if you eat that Big Mac every day for lunch.
Yeah,
you're gonna
and I know
die.
I'm
You
an
already
idiot
know
for doing
that.
it.
Okay, if I could interject, we
I'm
could,
an idiot.
we could continue on this for quite some time. Just real quickly, you said that people need to be shamed. I'm not sure if you heard the slide about shame and embarrassment. that mark of the stigma is not a motivating factor in any way. And sir, it sounds like you've had some really exceptional experiences in your life that have not been positive with folks with certain conditions. I appreciate you speaking up. I appreciate you being willing to take a look at this, and I hope you continue to do that.
I am.
And I invite you to join our coalition. Come to our coalition meeting.
Thank
That
you.
would be incredible. Yes, the gentleman in the back there had a question.
First of all, I see this meeting today as an opportunity for us to be more of a community.
Yes.
And to commend this officer for the years he put in service.
Absolutely.
That's-
Absolutely. Absolutely.
But as a community, this officer ought to have a list of people instantly.
Resources.
He could
Absolutely.
plug into this family and not tell them to go to this organization, but a representative goes out to that home and builds a network of friends. Because realistically, when that person is stigmatized already, the best thing they can get is a family of friends
Absolutely.
that accepts them for who they are, right where they are. And then they've got a network to keep them from falling into the darkness of the day. If that officer has that,
Right.
And
he
that's
will
what I'm
not have to
asking.
spend so much time with one home when there's 100 homes that needs him now.
It would take the burden off him. I
Yes,
agree.
And then we become a facility of change
Right.
in this room where all of us admit we struggle with depression. That's the beginning pebble in your shoe that will take you to a place that the officer has to come to your home.
Exactly.
If we start making that more acceptable in every network of change that we have in this community, then the mayor's problem is easy, the officer's problem is easy. You have this situation, you call this number of people, we're at their doorstep helping the community be different, and a community of healing.
And exactly, I remember in the past, Nicholas County did have a LEAD organization, law enforcement, is it advocacy division? Is that still active? It's still active. So we have that resource. So we could put that into action. A lot of it, as you said, it's coming together as a community. It's not staying in our little silo. I'm a teacher, you're a therapist, you're a doctor. It's sharing. It's that comprehensive plan that Andrea talked about. We all have a part to take in that. And indeed, as she said, no one thing's going to fix it. No one program, not arresting people, not recovery. We all have to come together to make that work, and that's an excellent point. So communicating to each other. Again, I'm going to tout the Nicholas Intervention Coalition as kind of your lead agency, and it's really the organization that brings it all together, because we do reach out to every stakeholder, every group. We are all inclusive. We want everybody at the table. So yeah, we've got your email. We'll invite you to the next meeting, I'm sure. Yeah, Mayor Schaefer.
Cheryl, what I'd like to say is I just had a wow moment when you gave your presentation. And of course, I understand the challenge of law enforcement because they're in the heat of the moment dealing with a lot of this stuff. But the wow moment I had is being a member of the coalition and the prevention committee specifically. They've been on a tour of this presentation of the data and the information that came out of the schools. Hand in hand, I think what should have happened with those presentations is a presentation on stigma. Because I have a real life situation that I've been dealing with at the city here recently with an individual that's a quality individual, struggling with addiction, and the number one issue was the stigma. I mean, everything you said just resonated on what the issue was with that individual and getting where they needed to go until it came to their unfortunate situation where it finally climaxed and then it was forced. But more important than that is the judgment that I've taken on the handling of the situation because I understand the stigma. And I can't say that I understood it the way you presented it, but I think now there needs to be another tour of the same round of folks that have been, and we're talking business people, but not just government leaders. The coalition's presented to City Council. I actually helped in the presentation to the Board of Education here today and County Commission. And really, hand in hand, what would have been good for me is that presentation be given before the coalition data so that people understand what these people, what these addicted people are dealing with, because that's the very issue I dealt with getting this person to treatment.
Yeah, I agree. That's really very important. And I'll tell you another little short story. I don't know how we're doing on time. I haven't even looked. But several years back, again, I mentioned I'm from Pocahontas County, we had the opportunity to apply for a grant to establish a, not exactly a recovery home, but after recovery, like a sober living situation is what they called it back then. So we were going out into the communities because we need to talk to folks and say, hey, here's what we're looking at, here's what we want to do. And of all places, and I was not surprised, of all places, when I talked to communities about the opportunity to do this, the churches said to me, that sounds like a good idea, but not next to me. And I'm like, whoa, boy, I would much rather know that there is someone in my community in a sober living situation that is in maintenance, aftercare, whatever you want to call it, because I shared with them, guess what? You don't know what's next to you right now, possibly. So the stigma's there. Like I said, this the article that Amy wrote, it really just gave me encouragement that if we're reaching out to farmers and really, kind of letting folks know what's going on everywhere, it's really encouraging to me, and I love it a lot. I appreciate your participation so much. I've actually enjoyed answering the questions, and your help for doing that. I appreciate it.
So guys, we're going to take just a quick 5-minute stretch break, and then when we come back, just take your seats and we're going to start kind of, I think it's the fun part of the program. It's the most interactive part. So again, stretch your legs. You want to do lots of training. So I'll ask you individually to answer some questions, and then I'm going to ask you to join groups of 4. And then you're going to join groups of 8. And if the numbers aren't quite exact, that's okay. It's about just bringing those ideas together. So the questions that I want everyone to ask here are, what opportunities can you identify? Or what is something you learned here today that you're going to help close gaps in our community? And then the next thing is, what can you do to help support change? So internally, we all talked about how we can all be part of this. We all have different roles to play as persons in this community and people that work in this community or live in this community. What can you do to support change? So I'm going to set my timer for a minute. Everybody has notepads at their table. If for some reason you've used all of those, graciously taking notes during these great presentations, let me know we have more. So we'll give you 1 minute for those questions.
Yeah, Little League baseball coach right here.
Still kind of talking among the opportunities that we want to identify to help close those gaps. So we're with Camden and we cover multiple different counties. So our county, some of us are in Nicholas, some of us are in Webster. So the people that are here in Webster, we have many gaps to cover or to try to close in Webster County. So what we're trying to do is, at least us two, we're learning what gaps you guys have already started to close, what gaps you're currently closing, and maybe some stuff in the future. So for us, I think more community engagement is crucial for at least Webster County or the surrounding counties for Nicholas County. And finding ways to meet people and having our public come to our community events, getting the word out there, which Nicholas County has done a great job so far in doing that. But I had community events. What else did we just talk about? Teen court. We were talking about teen court. I think that's huge with the youth. So we work predominantly with the youth schools. Teen court and getting that program out there, I think, is amazing, an amazing program. And that's something that we really, really want to do.
We also went with engagement and community. That's very important. We also went with education. We work in the schools implementing what you saw with the 9th graders, and we're starting in 3rd grade or coming sooner, so hopefully we can catch up and make that better. And I think that's very important. Educate the community is very important out there.
So, like she said, we work work in different types of schools, and I think we do curriculum with the youth. I do K through 12, and what I've noticed teaching the curriculum, at least in the last semester of in the schools, is these kids need to learn about it. So I actually had a kid a couple of days ago at a baseball game, and was like, Miss Amanda, she said, guess what I found? And I said, what did you find? And she said, I found a vape on the bus. I didn't know what it was until you told me in the class. And her mom happened to be in the concession stand working. She just happened to be that way. And she said, I did not know, she even knew what a vape was. I didn't know how she would know. And she said, I said, well, what did you do whenever you found the vape? And she said, well, I told my bus driver and I knew to stay away from it. But these kids, the parents aren't talking to the kids. And I knew that. She was like, I didn't even tell her what a vape was. We don't smoke, we don't vape. But me being in there, she was able to at least identify it, know that what it was able to tell the bus driver. But the kiddos, even the younger kiddos, getting that education out there is important.
We didn't really get too far into this. We were having a different discussion, but the things that we haven't talked about were churches being more involved in the communities, opening their doors, being more engaging with everyone instead of just the individuals that are in the congregation. After-school programs are crucial for kids to have that time when parents can't be available. And one of the biggest ones that we talked about was handled care. And while it's a great tool for all of these kids, it doesn't seem to be being utilized as it should be or could be. So that was handled care.
Oh, yeah. The second one was
After school.
after school program.
Obviously, I'm gonna put blame, and I push blame on the DHHR. DHHR reviews too.
Hello, so our group talked about an opportunity with the Family Treatment Court, that, these youth are affected by what's going on in their families. And there's an opportunity now, as they're going through this process, or seeing their family members go through this process, to reach out to the youth. So there's an opportunity there. We talked about lunch and learns. Liz had brought that up. Parents attend the lunch and learns at school, so that's an opportunity to engage with the youth and the parent at the same time. And we also discussed handle care, and as an opportunity, and maybe looking at the possibility of DHHR being able to initiate some of those referrals, and what that may look like to help improve that system.
So our group went over that we need to extend more stigma trainings out to our community, along with trainings for what each substance is and what it does to the person. More community engagements and community events that most of the law enforcement and public officials get involved in as well. Utilizing people with lived experience in instances like Lefty suggested, and then reiterating that people that attend NA, AA, or church tend to remain sober, and inviting those people to those things regularly.
Hold on one second. We're gonna slow down for Kim. Are you caught up? Sorry, Kim. What was that last one you said?
Utilizing experience.
Lived experience, tears.
Utilizing.
Yeah, utilizing people with lived experience.
Something else.
Reiterating that people who attend NAA or church events remain sober. So just continuously inviting them.
Community.
Yeah, it's community.
Addiction is connection. Connection with, yeah.
Your handwriting is really.
I can write good, but I can't spell, so put that together.
Community here.
Okay, so what was the,
Encouraging community with people with lived experience.
Okay.
The recovery community. Give you one more second. I don't want to rush the process, the artistic process. All right, we're ready.
Okay, so a lot of what we have has already been said. Better communication among the community, and I know Amy mentioned that the coalition actually has in process a wonderful resource directory that can be shared. Again, becoming an active member of the Nicholas Intervention Coalition. I mean, to me, that's the hub. You know, if all these sectors start going to those meetings and participating, and you don't have to go to every meeting, you know, you can, you can send different people from your agency, but I just think that's the hub. Education, evidence-based program, especially for our students earlier and earlier. Middle school is kind of almost too late for some students. Increase juvenile court referrals by more from the parents, you know, to get that communication out to parents that you can refer your student. And what else did you want to say about that?
Juvenile programs.
More juvenile programs to involve students. Who next?
You.
We're not giving it to Lefty. I was going to say, don't give it to Lefty.
We have about a lot of the same things, but my sector and Aaron and I, we do a lot with the youth, and I feel like the youth is where we can really grasp and catch a lot of different evidence-based programs for that. So, like, we just joined with community and the coalition and Camden. We just had a huge event last week in Summersville where we had 600 people come, and that was all free to the community. We had the parents come out. I had so many parents, churches. It was a unity. All the politicians were out, and they were serving and helping the community. And I thought it was great that kids could see the police officers out as like a good example, rather than being at the schools all the time and having to pick them up because they're in trouble. I thought that was a really good. So I think that building that with the kids and the youth is really important because they do go home and start talking about it to their parents. And we were talking about, you know, you need to start earlier. Middle school's too late. You need to start in elementary. And we all probably remember DARE. I mean, I still remember all those commercials. I think that that's important. And community involvement, getting with your local churches and your teachers, because teachers have a lot of different frustrations as well as law enforcement. And I think that they deserve a lot of the resources, and educating them on what mental health is too is important because they see it every day and have to keep doing it.
All right, so I'm gonna let Gary talk here in a second. But before I do, I want to mention something too. Like I think you hit it nail on the head. It's communication, because there are all these resources that are available, but like the people that need it don't know about that. You know, like if you look here, I was a principal for 3 years, and like I had one handle with care call, and that didn't even come to me. Like the attendance director called me and said, "Hey, this is what's going on." So like. And I know that there were more times that there should have been handled with care. And that, I'm not calling the police officers out or anything like that. I'm just saying that, like, I think that...
Hey, Josh, could you explain what that is, handle with care?
So you get a phone call, and it says, hey, this student, there was a traumatic event that took place with this student. You don't know what it was. Now, you have an idea because of the community, and you have parents and, you know, teachers that are in the community, and they say, okay, this is what's going on. But, like, they tell you that, and it's just kind of like, hey, if this student comes to school tomorrow, just keep an eye on them, right? It's like, don't expect a lot out of them, just love them, you know?
Their behavior might be a little bit different for that
Yeah.
day and more challenging than either.
Can anybody make that referral, or does it have to come from law enforcement?
So,
It can come from anyone you call, like the way you used to.
Reporter, like if, you know.
We used to call dispatch.
We used to do
911
through dispatch, but we had an issue there. It wasn't getting done. So now we have the QR code at the office, and anybody can do it from their phone.
It would definitely be an area that would help if we spent some time talking about it and hashing out the process so everyone knows the process and we're all on the same page.
So I will offer to pull together a group of partners that work with Handle with Care, so Board of Ed, law enforcement, the Child Advocacy Center, the principals, CHHR.
I think some of the perceived where it breaks down is sometimes people think they need to know information, but they really don't need to know. So if certain teachers or administrators, like I'm a school social worker, if I don't get the information about the handling of care, my response is, well, I didn't need to know that, and someone else is in position to take care. We have to trust that, but we all have to understand the process.
Absolutely. But I think it sounds like that we need to just kind of go over the process in our community, because it doesn't sound like that process is, that there's some disconnect. And I think that everyone here agrees that this is a beneficial program, and certainly we have to take care of our kids, and we know the effect of trauma, and we've talked, you guys probably have heard about outburst childhood events, and so we need to do our best to be creating that loving, caring environment for our kids, and having information like that is
And I think the school system has done a good job, especially in Nicholas County, because they've hired extra social workers, counselors,
assigned to every school.
like that. But still, with the education system, especially after COVID, like there's a lot more that's expected out of teachers that they aren't trained for.
Well, I'll give you, I was working with a student one morning, and I hadn't gotten any calls, but he also said that his mom's boyfriend had to hide in the closet until his police officer left. So I'm thinking, okay, there's some sort of altercation there, but that might be a good example, because then the police came back to take him away, and this child really didn't understand it. So, and I wasn't sure of what was going on. That's an example of, if we're all communicating, we're going to help that child process it in a more positive way.
But I just think like communication, there are a lot of representatives here. And like everybody comes there are a lot of these meetings that take place. And it's up to the person that is here to go back and tell their organization what's going on.
Yeah.
So like I think that's where the disconnect is, because it's not, I'm not accusing anybody, I'm the same way, but like it's life happens, a lot of other things happen, you know? So like if there's a way to communicate that, and like to communicate events, and not just for, you know, you're talking about your event, that's great. Excellent, 600. But like, how many of the at-risk families that we're talking about? And you're talking about like your, like during school, you know, the percentages are so much lower. But then like after school and weekends, it jumps up. And so I'm sure that like your parents are the parents that are involved. But like if you look at those at-risk families, how do you reach them? And that's the thing that's happening everywhere. You know, because like those are the kids that fall through the cracks. Those are the ones that, you know, they might not know about that event, and especially the younger kids that don't have a choice. I mean, it's, you know, their parents are the ones that determine what they do. And so how do you reach those kids? So then you start looking at like transportation issues, like how do you do that, you know? And then that's a huge thing. I used to work in after school programs, and it was for at-risk youth throughout the state. And the biggest thing was transportation. And you know, some programs were able to provide it, others weren't. And so I just think that is the biggest thing. Like, where's the disconnect? How can you, as a community, you're offering great things, but how do you get the people who need to be there, be there?
Yeah, and having the information and then creating action from that information.
All right, some of the things we came up with was, you know, we're back to education again. We all have a circle of influence, and we all have a circle of concern. So inside our circle of influence, we can actually educate ourselves and share that information out. Your family unit, your kids' friends, things like that. Child interaction, it had been identified that, you know, based on the different age demographics, that you have different levels of care and concern and risk and those types of things. So utilize programs such as Sparrows Youth Coalition to educate, train, and reinforce, you know, what we want kids, how we want to interact with other folks, how we want them, you know, the training we have on them. Engagement with the PTA or PTOs, I think it's called PTO nowadays, PTOs, and reinforce that. Basically, we're just hitting the kids anywhere we can get them with the same information. Better utilization of deferment programs such as LEAD. I think if we can push that information out there and have that, and have it utilized, that we could actually address the law enforcement aspect as well. You can pull some of that stress and strain off of them. And then one of the others we had was engaging with parents of adults in addiction or recovery. You know, no matter how old you are, you know, typically you've got a mom and a dad, and hopefully you look up to them, respect them, and you know, you kind of take that as well. We had a little sidebar about GEDs over here, and I think that's also a very important aspect, and I learned a lot just here in the past couple of minutes.
all the groups reported out? Great. So what a great group. Thank you guys. That was great. I know that sometimes sharing ideas and presenting is a little bit out of people's comfort zone, but I really, really appreciate it. One thing that I will say again is that, change takes time, and but it's worth the investment. So as we start implementing things and growing and working to enhancing how we communicate and work together, just know that does take time. It can take sometimes, not to scare anyone off, but up to 20 years to start to see change. We are looking, for things to trend in the right direction, but really it does take time and generations to institute this, but it is worth our effort. And again, I think that we do have such a dynamic, caring community to where this is possible, and I haven't felt that way in other places I've been, and sometimes there's lots of obstacles, but I feel like here people are willing to put some of those things aside and do what's best to help our community and the future as a whole to be as healthy as we can be. So again, thank you for your attendance. If you don't mind, please remember to put a sticky on, I'm going to say 2, because we have less on the board than I expected, so 2 of your top priorities. The other thing, I'll be sending out a follow-up survey that just talks a little bit about, one question that I always ask is ideas of, number one, how you feel that it's best to receive information, whether that's email, social media, SCTV, radio, and then how you think we can best reach our at-risk youth or some of the other sectors. So that's always the challenge is how do we get that information out? So I certainly would welcome any ideas related to information sharing and reducing some of those barriers and silos. So be looking for that. We will document. And then certainly, again, our next Nicholas Intervention Coalition meeting is next Thursday at 11 o'clock at Summersville City Council Chambers. We welcome all of you there. There is in your packet a link on the back of one of the placards to the Facebook page, and there's a link to shop membership as well. So thank you again for coming. If